When a patient presents with bloody diarrhea, clinicians must distinguish between etiologies requiring opposed interventions. We categorize the pathology into 3 groups: bacterial infections, inflammatory bowel disease, and hemolytic uremic syndrome. For this model, we'll isolate our focus to the bacterial pathway. In an acute clinical setting, differentiation within the bacterial category must occur before laboratory cultures are available. This diagnostic process relies on 3 specific parameters: core temperature, the anatomical location of pain, and patient history. Misidentifying the specific pathogen leads to iatrogenic harm, as the intervention for one strain may be contraindicated for another. For example, immediately administering standard antibiotics to certain bacterial strains can unexpectedly initiate a dangerous cascade of severe systemic complications. Similarly, utilizing standard antimotility agents can exacerbate the infection across all bacterial causes. The objective is to construct a decision tree that routes the patient from the chief complaint to a targeted, safe therapy. In cases of bloody diarrhea, clinical observation must dictate the management plan, superseding the instinct to immediately prescribe broad-spectrum antibiotics or antidiarrheals. The first bifurcation in the algorithm is determined by a thermometer reading, the presence or absence of a high fever. A presentation of high fever, bloody stool, and tenesmus indicates a Shigella infection. Tenesmus is the continuous, painful urge to defecate, even when the bowels are empty, serving as a specific marker for the Shigella pathway. In the absence of a high fever, the diagnosis hinges on the timeline and progression of the bowel movements. Shiga toxin-producing E. coli, or EHEC, presents with a distinct progression, starting as watery diarrhea before transitioning into bloody stool. This transition is frequently accompanied by severe abdominal pain. STEC is often clinically associated with traveler's diarrhea. Identification of STEC requires a significant departure from standard infectious disease management. Comparing the speed of onset between these pathogens allows for a more refined clinical history. A thermometer reading alone significantly alters the suspected pathogen and dictates the subsequent management protocol. Spatial pain localization provides the next diagnostic metric, specifically focusing on the right lower quadrant of the abdomen. Severe pain in this region often leads to a preliminary diagnosis of appendicitis. However, true appendicitis does not present with bloody diarrhea. When right lower quadrant pain occurs alongside bloody diarrhea, the suspicion shifts to a Yersinia infection. We then look to the patient's recent dietary history as a primary diagnostic indicator. The consumption of undercooked chicken is a specific historical marker for Campylobacter enteritis. Establishing this exposure history provides a clear diagnostic path, as the correlation with the pathogen is strong enough to inform initial treatment. Recognizing the intersection of localized pain and diarrheal symptoms allows the clinician to rule out surgical emergencies and focus on infectious management. While evaluating infectious causes, the clinician must also monitor for mechanical anomalies that present with similar abdominal pain. A critical differential in this context is intussusception. This is a pathology where a segment of the intestine slides into an adjacent part, causing a mechanical obstruction. The stool in this condition has a distinct jelly-fresh red appearance. This jelly-like consistency is morphologically different from the liquid blood seen in bacterial infections. Unlike bacterial pathogens, intussusception must be confirmed via ultrasound. Identifying the morphology of the blood in the stool allows the clinician to shift from infectious disease protocols to urgent mechanical imaging. Once the pathogen is isolated within the algorithm, the pharmacological routing is binary. For both Shigella and Yersinia, the first-line treatment is the antibiotic ceftriaxone. Campylobacter requires a different targeted approach. Azithromycin is the first-line therapy for Campylobacter infections. Regardless of the pathogen, one pharmacological restriction applies to the entire differential. Loperamide must never be used in any patient presenting with bloody diarrhea. Halting intestinal motility traps the bacteria and their toxins within the gut, increasing the risk of systemic absorption. In the management of bloody diarrhea, knowing which medications to withhold is just as significant as selecting the correct antibiotic. Turning to the STEC node requires a complete reversal of standard infectious disease logic. Although this is a bacterial infection, administering antibiotics to a patient with STEC is strictly prohibited. The only acceptable intervention for STEC-related traveler's diarrhea is fluid replacement. If antibiotics are used to kill the STEC bacteria, the resulting cellular rupture causes a release of toxins into the bloodstream. This toxin release triggers hemolytic uremic syndrome, or HUS, which can lead to renal failure. The clinical progression toward HUS follows a history of diarrhea followed by 2 new clinical signs. These markers are the onset of hematuria and a significant increase in serum creatinine. Rigorous application of this algorithm prevents the error of treating STEC with antibiotics, protecting the patient from iatrogenic renal failure.